Hello, everyone. Welcome to our bleph webinar, What to Expect Before, During, and After Blepharoplasty. My name is Melissa Casanova. I'm our marketing director here at VEI. We're thrilled to have you join us this afternoon, and we have some great information in store for you. We really appreciate you sending your questions in advance. Dr. Bearden is going to go over all of those and do his best to answer everybody's questions. Feel free to submit questions in the chat. Dr. Bearden can also review those at the end. Just please keep yourself muted. And this webinar will be recorded and available on the website afterwards. So if you have to leave early or if you missed it and you want to watch it again, feel free to check that out and rewatch it. And yeah, Dr. Bearden, if you want to tell us a little bit whenever you're ready to take it away.
Thank you for taking the time to come back in today. And, basically I wanted to run today as kind of a QA session with the hopes you guys will pipe up. And if you have any questions, please pop them into the chat thing. I'm going to try to keep an eye on that and we'll answer as we go along. I did get some before the meeting today, and so happy to kind of address those first. And those are probably spur other questions. And then, certainly we can get to the questions, commonly asked questions, during exams and consultations. And so anyway, without further ado, I'll jump into the first question I received, which I thought was a really smart one. And by the way, I didn't get into this, but the main topic is blepharoplasty and what we do a lot of here. And I'm going to throw in there with that kind of fixing, eye muscles or levator muscles for that kind of repair as well. That's a blepharoplasty sort of. It's very similar and it's a way to open a droopy lid, but some folks need one or the other or both. But I'll talk about them kind of in tandem today. But that's our main topic, is the blepharoplasty. And so the first question is, someone had a toric IOL. This is a very technical question. Somebody had a toric IOL put in with their cataract surgery. And they're asking me, will a blepharoplasty affect that? That's a really good and smart question. The answer is usually not. We can typically take a look at you and kind of figure that out. For some people that have really super heavy lids, it can actually create, an aberration in kind of how you see, to the point where people will correct that with glasses. Then you fix the eyelid, and then that aberration's gone. So the question is, if I have some permanent way of fixing that aberration, and then I fix the eyelids, will that affect that lens? And will I need glasses afterwards or contacts after doing that? And that's a really smart question. We don't usually see that with blepharoplasty. Levator ptosis repairs, we can see that with more commonly. And so basically, we just kind of take a look at you and kind of see. But the answer to your question is not, usually not. And so that's more of a kind of take a look at, I think. But it's a really smart question. And what we'll tell some people who come in, they have really heavy lids, and they're going to have some sort of, procedure done with their cataracts. We'll say, hey, we probably got to fix the droopy lid first, because it's bad if it may impact what lens you need for the cataract surgery. So we'll do in that sequence is a smart play for in some situations, not always. But again, we can take a look at that more closely at the time. Any questions or thoughts on that? Comments? All right, so on to the next one. People ask often, and this is one of the questions before, is will insurance cover my blepharoplasty? And the answer is sometimes and maybe. The insurances they publish very specific criteria for what they cover, what they don't. So we know they publish that now. That hasn't always been the case, but we know that now. So typically during the exam, we can look at you and say, yeah, you're going to meet criteria or not. Even if you do, we still have to go through an authorization process to get authorized. And so we kind of do that for you, but we can typically tell you up front whether it's covered or not. We get surprised sometimes they won't cover something that we think they will. We're pretty good at predicting that. And of course, if it's something the insurance does not cover, then we can certainly give you the prices for doing it as an out-of-pocket thing, which a lot of patients like to do if their insurance will not cover it. But again, that's something we have to take a look at you kind of see there. Any questions or thoughts on that? Okay. So I get comments often. What I hear a lot in my patient consults is I'll hear people say, I don't want to look like Kenny Rogers or insert your other celebrity who has had a bad outcome that they see on TV all the time. And my answer is, I don't want you either. And so I always tell patients, and I encourage you to look at. I have an Instagram page in our Beard and Plastics, and we have a website that has pictures as well. It's always top of mind for me to have you have a natural appearance afterwards. That means hopefully afterwards people have a hard time putting a finger on what you had done, and just that you look better rested and just more alert version of yourself, a little refreshed. That's really a win. So we're not going for super surgical looks. So natural appearance is always top of mind. So we don't have patients that end up looking stretched and kind of, distorted like, again, Kenny Rogers or insert your other celebrities. So that's an important point I make with patients a lot. The natural appearance is really the way to go for good cosmetic outcome. Other questions, how long do I have to wait to have surgery? So typically we see people in the office, and once we get authorization or you decide you want to do it, we try to keep our schedule. We'll get you in the books within about a month, give or take a week or so, depending on the situation, but we try to keep it about that. So not a long wait. So that's about a month is the answer there. I get asked a lot, do you use laser for your blepharoplasty? And the answer is yes. When I think it's appropriate, I use it for everything, but for a lot of cases I do. For me, it's a great tool for kind of dissecting that sort of stuff. There's some areas I think it's kind of heavy-handed. I like to, for a skin incision, I like to use just a standard scalpel, but I use it for dissection beneath there. To me, for the skin, it's like, killing an ant with a sledgehammer. So thin the skin of the body, I think it's just maybe not needed, but I definitely use it in some areas, and we certainly use it for tightening the skin for resurfacing as well. But I do think it's a great tool and used in the right spots. So it's a good addition. So other questions there on my phone. So I'm gonna look down at the camera here. I get asked this often as well. And by the way, I hope you guys pipe in with some questions because I'm going to run out of here. I have questions here pretty soon. But people ask all the time, are my eyes going to close afterwards? And the answer is yes. Off the bat, everyone doesn't close all the way just because your windshield wipers are kind of bruised and swollen. They're not going to blink as briskly. And so for that reason, that's a temporary thing. People get back to their baseline. And we ask people to use artificial tear drops and kind of lubricant drops in the interim to kind of keep them getting dried out. But I tell patients that that period of being a little bit dry and scratchy is an investment of sorts, because if you aren't having some of that off the bat, I probably didn't do enough. And you might be back doing this again in a few years. So it's an investment up front. So you're not back doing this in a few years. And so it's something we really stress. But having said that, some patients come in and their eyes don't close to start with. We kind of talk that through with patients. Some people are just built that way. They tend to be drier in general. There are things we can do to help people along during that period, which kind of makes them more comfortable until their natural blink and closure come back. And for most patients, that's a couple of weeks. Some people take a little bit longer, some people shorter, but there's ways to manage all of it. It's the bottom line, and we get you back to your baseline. It's super duper rare for someone to end up being drier when it's all said and done. They're finished healing than when they started. And even if that's the case, there are things we can do for it. So I saw there was a pop-up, there was a question I got somewhere. So I got a Q&A thing down here with a 2 on it, but I don't see any questions under my chat. Should I just hit that?
I'm not sure. I don't have a Q&A, but if you do, yeah.
Oh, yeah, I can see it. Let me just move this to the side here.
Yeah, you guys, if anyone has any additional questions, feel free to.
Yeah, jump in, put them there or in the chat, the chat, and I'll answer these now. And I also have a kind of the lookbook sort of PowerPoint presentation that I often talk about in the office. And I'm happy to show you some examples towards the end of what we do and kind of examples of all things we're talking about here. So the question in this panel here is, does this procedure ever include a brow lift? That's a great question. I was going to get to that. So people look in the mirror and they often will see, they say my eyes are heavy, right? But a lot of patients have brow issues, which contribute to what you're seeing in the mirror as well. Some people don't, but those that do, some people have very full brow fat pads. Some people have brows that are lower than they need to be, than they ought to be. So one great technique I have is called an internal brow, where I can actually borrow the same incision I would make for blepharoplasty, which is the standard lid lift incision we've heard about or you've seen probably online. You can actually borrow that incision and kind of tunnel up and do work to address the brow position and fullness um, at surgery at the same time. So some patients I will recommend, hey, I think you're going to be happiest and get the most longevity working your brows as well because we're always battling brow descent. So we go in and remove some skin with a blepharoplasty, which is what that is. But your brows fall another centimeter in the next few years. It's just going to squish up what's left behind like an accordion and look as if you've grown more surgery, even though you haven't. So really addressing the brow position and slowing that process down is really key, again, to longevity. And so why I do these with the intention of you not having to do it again, hopefully, but if not, giving you the best chance you can to space them out apart as much as possible. So yes, I probably do brow lifts or brow sculpting. There's nothing we can do through that same incision. I would say for a lot of the operations I do. So we always look at that and make those recommendations if they're pertinent for that patient or appropriate for that patient. Good question. Um, so the other question here is, does having blepharitis affect being a candidate for blepharoplasty?
Hmm.
Yes and no. It's not a deal breaker, but people who have a lot of blepharitis tend to have, and again, there's grades of it. There's very mild blepharitis, there's really super severe blepharitis. People that have a ton of it, they just tend to be inflamed in general. They just tend to have a red look to them and kind of have more inflammation. That makes you bruise more and bleed more at surgery and bruise more in general. It takes a little bit longer for recovery for the swelling to go away. So having baseline inflammation can kind of prolong the process. Again, it's not a deal breaker, but if I see someone who's really bad blepharitis, then we'll do some things to kind of work on that in conjunction with doing surgery beforehand to kind of get that as under control as you can get it. Having blepharitis, it isn't something that you catch. You're just kind of born with that skin type typically. So there are things you can do to kind of manage it. But in a lot of cases, you're never going to eliminate it all the way. So again, it's not a deal breaker, but we like to optimize it before we do surgery for a lot of patients. So I'll go back to my list here. If there's no other questions, I have this other chat thing. You see, somebody left it in there. And by the way, I can't hear anyone talking on y'all's end, but I am known to talk more quickly than I should. So if you find me talking too quickly, hit the raise hand thing and tell me to slow down. Sometimes my mouth can't keep up with my brain. Um, so so I get a question all the time. People say, "Hey, they come in to ask about their upper lids being droopy. They want a blepharoplasty." And by the way, I didn't get into the details of what that is precisely. I think if you're here, you probably know what that is, removing extra skin in the upper lids. But if you want me to, somebody wants to really dive into that, I can do that, but I don't want to bore anyone. But what I'll get in conjunction with that, people will often ask, hey, can you work on my lower lid bags or lower lid hollowness or dark circles while you're there? And the answer is yes. We do that for really a lot of people. They want to tackle that while they're there in the sleep anyway. Um, I have a note about that. So the way I typically do that is we can do that at the same time. And what that often involves, and that's a whole, we can dive into that more specifically with the pictures, but the way I like to approach that is, the puffiness is usually fat pushing forward, but a lot of patients have some deflation at the top of their cheek, called a tear trough is another name for it. And so a really great technique that I use a lot of to treat that is we do a blepharoplasty. This might be a good time to bring a picture up and show what I'm talking about. Let me try that really quickly here. Let me share. Here we go. Good. So I'm going to make this the slideshow. So
Perfect. I can see it.
I'm trying to make it to where it's just a slideshow and all the other stuff.
Yeah, at the top where it says slideshow, just hit the on the right, almost there.
There.
No,
You
one
know
more.
what? My windows, I have a little window covering. That's why I couldn't see it here.
Ah,
All right, there we go. So an example of this is, you guys see that okay?
mm-hmm.
I don't.
Oh, no.
Okay. So to scroll through this, here we go. So an example of this, so you got a patient here. This is a good example. So this patient here has kind of puffiness or bags, and she's got fat pushing forward here, right? But she's also kind of deflated right there. And so that deflation of the cheek is a very subtle but profound aging feature. And so the way I deal with that is, again, we can hide it in the incision inside the lid, which is kind of cool. So there's no skin incision for the lower lids, but we remove some of this fat that's pushing forward, but we save some of that fat and we kind of tuck it deep in here to fill into the face of your hollow. So we shift some volume here where you want it from where you don't want it. And you can see here, that's a little more convex and full there. And we sculpt the fat above it. So it all kind of blends in together, looks nice and natural. And that fat we took in there has some blood supply, so it stays there forever. So it's kind of like filler in that area that lasts forever. And so it's a really dynamite way of dealing with that. I'll show you some other pictures. This lady here, same deal from this side. She's full here. We use that fat and we swing it down here so she's more full where she was hollow. And that's a great way. It's called that technique is called a fat transposition or fat transfer. And that's really, here's another example, same thing. She's hollow here, fat pushing forward. There we tuck it in the top of her cheek. It's more full. It all kind of blends together. But that's really kind of the state of the art. A guy named Guy Mastery first described this. He's a guy I know who is in LA, probably back in 2010. And it made so much sense. I adopted it back then. And so I think it's been a really great home and way of treating a lot of issues with the dark circles because it's a lot of it's a shadow effect. It's not really darker skin. So by putting more volume there, you kind of cover that up and really fill it in nicely. So that fat transition is a great technique. I do this for most of my loaded blepharoplasties. And I think it is, more than these anyone in town. But I really believe in this technique. I think it's a fantastic one and really gives great results, really natural results too. And I like the organic way of kind of using your own what you got already to fix the problem versus sticking foreign stuff in there. So it's a great way of fixing the problem organically. I feel like here's more pictures of lower lid puffiness you can see there, and I'll do a couple more of these and I'll get off this bandwagon. But I think it's a great technique here. Here's an example of someone who's really
Wow.
big puppy got is all the hollows kind of cut off there. You can see how that blends in well. Um, Patients who have a lot of swelling and festoons. Here's a patient who had kind of bad filler that she didn't like. I took the fat here, tucked it down here, and kind of filled in the difference and kind of blend that all together. So it's a nice organic way of taking care of this. And hopefully this patient, if just pay attention to the right hand picture, hopefully, let me go back there. I don't know how to go back. I think I can only go forward.
Oh, no.
So, anyway, you can see and go forward. Hopefully, looking on the right side, these people look like they haven't had surgery till you look at the picture on the left side. This guy here, for instance, he looks nice and natural. If you see the left, you would never guess he's had surgery. And that's why I mentioned going for natural appearance is always is always top of mind and should be, because that's what most patients want, I feel like. And so you get
Great.
more bag
I have
pictures.
a,
Upper
I
lid
have
wise, we
a
talked
question.
about upper blepharoplasty. That's what we did for her, for instance. And a lot of these patients, I didn't really get into this, but we hide an incision, a lid crease up there, sculpt the fat, and get rid of some of this extra skin, so it's nice and cleaned up there. And you can see her lashes better. She's got a little platform, and just really it looks nice and natural there. So anyway, that's what we do all the time, and people are generally pretty happy with it. So any questions about that in specific? I think I can only share. I can't see the other screen at the same time. So have any questions popped up, Melissa?
Yeah, there was one more question that came in. Does having, not to do with this, but does having male pattern baldness mean brow lift is not a good option?
Good question. So male pattern baldness makes your hairline go up, obviously. So for a lot of brow lifting techniques that involve like a stemmed insert incision across the forehead or endoscopic, yes, it can be a problem because you got a scar up there that you can't hide. But one of the beauties of the technique that I use through the eyelid incision is that, having male pattern baldness doesn't really matter because there's not a new skin incision to hide. So it's a great way of, addressing the brows through an incision you're making anyway. And it's not as powerful as some other brow lifting positions, but for most patients, it's all they need. If someone needs something more powerful, we can talk about that. and we can do other types of approaches. But in general, you know, 9 times out of 10, I can make a patient happy, work through the IDA decision. So the roundabout answer to that question is no. If you're using the brow technique I'm describing, having male pattern baldness does not really impact it. So I'm going to stop this share here so I can see the rest of the screen here. Good. All right. So guess that was a question you told me is the male pattern baldness one. Any other
Great.
questions spurred about that, about those pictures or anything you saw there that spurs interest or create questions? No. Okay, good. I'm looking through my series of questions here. I get asked often. Yeah, other than basically what we kind of alluded to already about the brows, is that I think sometimes doing IDA stuff in isolation of addressing the brows is a mistake. I think you lose longevity and kind of you lose some of the harmony you have between the lid and the eyebrow, which you should have. So sometimes one without the other is not what you need. So I think addressing both at the same time is a really great way to do that. So I'm glad whoever brought the brow thing. That's a really smart question because it's often overlooked, but I think it's really important. So saw a new question pop up. Okay. So good. So pre-op and post-op, and they have surgery. So that's a great question. So I can walk through the whole process basically. So we see a patient in consultation, and basically I take a look at you. We can have a good conversation about what your goals are, what's bothering you, and then I can talk through what solutions we have for that. And sometimes that involves laying out, an array of things we can address or not address, kind of an a la carte, what bothers you, because I want you to know all your options, but let you decide what you want to do. And I always say to patients, it's really important to always, if you go home and process things, you have more questions, to always call or come back in. We all usually don't charge you for that because I want to make sure you feel good about what you're doing or not doing. So everyone's on the same page. But that initial consult, we cover a lot, have a long conversation, lay out options, show you pictures. I typically would have you see my scheduler who kind of lays the groundwork paperwork wise to eventually pick a date if you decide you want to, no pressure. And she'd also give you the prices for any uncovered portions or procedures at that time. So you have that in hand. And if it's something that requires pre-authorization from your insurance, she can start the ball rolling to kind of get that squared away. And then what happens is we would call you back once we have that. And that gives you time to process all the conversation as well. And then we say, hey, let's put this in the books and do it. And that's the point which we want to know. Do you want to do, say, the brow thing with the droopy eyelids? And so we can block out the right amount of time, or do the lower lids with the droopy eyelids. So we can block out the right amount of time. So that's the first step. Once we pick a date, the next step is to arrange to have a history and physical done with your PCP, or we have nurse practitioners here to do a great job of facilitating our patients getting in to see them, just to make sure you're okay and healthy to have surgery in general. And if we've asked you to stop any kind of blood thinners, which that's part of the conversation we have at surgery, if you're taking something like an aspirin a day or other stuff, we may have to stop that beforehand. Maybe that just depends on the patient and the surgery. But if you had to stop that, you get permissions from your PCP to make sure that's okay. That's really important. But we have that done. That's got to be done within 30 days of the surgery. And then basically, we have a surgery day. And there's sometimes allows patients to do some things preoperatively. For instance, I took the pictures down now, but with some of those patients, they have kind of crepey eyelids. Can we use laser tightening to tighten the skin to make it more taut? And I'll show that picture really quickly here. And so when we do that, for some patients, if they have more pigmentation than others, we'll often do some treatments before surgery to make sure their skin will tolerate laser and kind of too much. So we do some preparative things from that point. Uh, we example this guy here. you know, he has crepey skin here. We got rid of the fat, made the skin more taut, the laser, so that the wrinkling's better. And so that sort of stuff may require some pre. Another example of that is my annotation button is overlying the back button on my thing here, which is pretty hilarious.
That's happening.
Oh boy. Okay, I'm gonna quit doing that. So, but basically, when we tighten the skin, we have to do some preoperative stuff. And then a few days before the surgery, they'll call you and say, hey, your surgery time is so and so. They usually get you there an hour beforehand, get you ready for the surgery. And we do the surgery. And after you have a recovery period afterwards, we're using ice and the nurses are getting you all squared away and comfortable afterwards, and then send you home the same day. All of these surgeries are outpatient if I didn't cover that before, which is good. So we always, you got to count on about a half day to get there an hour beforehand, have surgery and around for an hour afterwards. You just count on that. And we work really hard and at the day of surgery to make things smooth for you. We get a lot of great feedback about our surgery center. People are really happy with the nurses and the care they get there. So that's a really good experience for people in general. And then we typically afterwards would see you back. Depends what we do, either the day after or within a week. That's an important thing to keep in mind. We always tell you that beforehand, so you had that information. And then the follow-up moving forward just depends on, what all we do. Some patients I just see once after surgery. They're doing so great. They're happy. We just say, hey, call us, you got a problem, follow up with the other doctor. Some patients we see back more often because they have, for instance, when we do the fat transition surgery, I use a suture the first week to hold that fat in place. I'll take that out in a week. People that have resurfaced, we'll see them back in a week and talk through changing the routine for taking care of the resurfacing with the laser. And so we vary from patient to patient, but which brings to the point for all the stuff, be it your post-op care or the surgery itself or the planning, we really try to customize what we're doing for each patient. Just, done well, this kind of work is not cookie cutter. We really try to tailor it to what your needs are, what you're looking to do, and then and respond to what you need as things present themselves after surgery. So we really try to not be too cookie cutter with stuff. I have some other questions here, which is good. I have one here that says, when I see your picture of blood, where I can't see any scar. Good questions. That was the great point of all that. So with the lower lid blepharoplasty, I don't create a skin scar. We can hide it inside the lower lid, so you can't see the scar, which is great. So that's really cool. There are techniques. I think it's I'd say in the early aughts, the oculofacial world transitioned towards using, the term is transconjunctival. It's along with basically making an incision inside your eyelid. And so people that do what I do around the country pretty much all do that. So there's no more skin incision. That's great because the skin incision would weaken the muscles and lower it for blinking closure. There's a little bit of a scar you can see in some patients. So the route I use just avoids all that. So it's a non-issue, which is really kind of cool. And so that's one of the beauties of that technique. So that's a great question. What else? Trying to think what else here.
And just to piggyback off what you said for the post and preoperative care, we do have a bunch of resources and all of your post and preoperative care instructions on our website. So I sent that link to someone earlier. Feel free to go to that page. There's a lot of resources there, and you go into great depth. So
there's a lot. So that's a great point. So that stuff's on our website. When you schedule surgery, we give you all this stuff in writing, and I say it a bunch. And so a lot of times for patients, I'll tell them something. They're like, "Yeah, I already knew that," or I was like, "Well, that's fine." We make sure you hit a lot so we don't forget it. So we want to make sure we rather overdo that part than underdo it. But there's lots of resources for the instructions, and they're pretty straightforward. So I'm trying to think other questions that may the consult fees. Yeah, we covered the big questions I get a lot at surgery. Oh yeah, another one I get a lot is does this hurt? What kind of pain do I have? So a lot of patients have had bad surgical experiences. the beauty of this is really, yeah, I give everyone pain medications. I'd say about half of those actually fill them, and then half of those use them. And when they do, it's maybe for the first night. So really, I hear patients all the time come back and say, I didn't have any discomfort. They marvel at how, for what we did, for the change they're seeing, how little discomfort they have. And that's not just to kind of toot my own horn, but I think it's really true. I think patients do really well. Part of that is the way I do surgery. I really try to, you know, there are ways to do surgery kind of slash and burn and just kind of go do your thing. But I really try to respect natural tissue planes. And so when I dissect and do stuff, I try to use planes that, for instance, bleed as little as possible versus just blasting through with cautery. I try to preserve your natural tissue planes. So I think that really creates less eyelid or tissue or skin injuries. So there's less recovery and there's less pain. So I really, people come back all the time. I never promise zero discomfort, but people come back all the time and just marvel the fact that they either took Tylenol, which for me, that doesn't work, but for some patients it does, but they use Tylenol and that's all they needed. And so that's
Oh,
great, but it's really, really, pain is not a big part of this, which is great.
that's awesome.
Um, what else? Any other questions from the crowd? Good question. So someone asked, is it, from an economic standpoint, is it better to the upper and lower at the same time or do them separately? I really tell patients, that comes up a lot. That's a good question. And so um, patients will come in oftentimes for one thing, and in our conversation, we'll think about the other. And I tell them it's really what bothers you. You know, there is a small benefit from doing it at the same time. Because you're already there, and there's anesthesia charges which are additive, and there's facility charge which are additive. So doing the same thing split in two segments, it is more expensive to do it separately. It's not a gigantic expense, but it's something. Um, Probably more important though is if both things bother you, going through one healing process is really seems to be more important to people even than the finances of it. And so, but honestly, we aim to please. And so if somebody really is adamant they want to do uppers and lowers or vice versa, we always honor that. Or people want to do it at the same time, we can do that. I had a patient recently who said she wanted to do one eye at a time, which we don't normally do, but she was adamant. She wanted to say, well, that's fine. We can accommodate, we can do that too. And so, we're pretty flexible, but there is a small benefit to doing it money wise, doing all those things at the same time. Because when you're there with a like an insurance covered operations, I think it works out to be a little better to do that as an add-on versus come back another day and doing it. So Melissa, can you think of any other questions? I think I've exhausted the kind of the FAQs I get in the office a lot.
Yeah,
And
yeah. I was trying to pull up any other commonly ones that we get that we had on our site. But I mean, you went through most of them. So,
yeah,
uh,
and so I would say, let me see here. Here. We got the same one. I got you. Okay. Yeah. Okay. Well, this is probably most people's lunch hour, and I don't want to drag this out any longer than we need to, but I want to make sure any questions are answered. But if there are no more, then I will sign off and hopefully see you guys in the office. And certainly you can, if you have any follow-up questions that you forgot to ask, you can send them to Melissa and she can get them to me. And hopefully we just see you in person and talk it through though. And that'd be the best way to do it always.
yeah, please call the office or email me. Feel free to reply to the emails that you've gotten, and we'll be happy to reach out and
Do
get
you
you
have a way,
scheduled.
Melissa, do you have a way of putting up on the screen our my phone number?
I can message it to everybody. Yeah,
Or
let's
I can
see.
just say it, I guess, but I just know the way to put it up graphically. But I would say so. Our,
Yeah, that's
our
probably
office number is 804, it's 287-4276. That's the main one. And then if you and a lot of things we discussed in the lower lids and upper lids and brow stuff on my Instagram page, it's Bearden Plastics is the kind of the handle.
Mhm.
And certainly that's another way you can kind of check out what I do and kind of my philosophy of approaching things. And that may spur some more questions on there as well. But we're always happy to try to field them. So But with that, I hope you guys have a great day and thanks for your time tuning in now twice to visit with me. I appreciate
Yeah.
that. The
Yep.
second time's a charm. And you guys have a great day and thank you.